Okay, everyone. Last but not least, this is our final presentation of the day. So why not wander on back to your tables? We're going to bring up Dr. Salvador Borges, who is working at Duke, to talk about PRRT and I believe some scans and things like that. So please put your hands together and welcome Dr. Borges. I think you go this way. Yes.
Okay, that
I'm
moves.
sorry, wait. So that's forward.
Oh.
For me, it's backwards, but this is
That's forward, and the other one is backward.
Yes, that's
And
right.
that's the way.
That's
Okay.
right.
Good.
Is that good for you, Renee?
All right. Well, first, thank you very much for having me here, and I have participated in one national meeting in near Las Vegas, but we were not allowed to go to the supposedly fun place. So anyway, I will try to go over some slides and show images that we do for patients with neuroendocrine tumor. My focus will be, of course, on nuclear medicine and scintigraphic studies. And then we're going to follow that with the PRRT treatment and how we do at Duke. And then some outcomes data that has been published. And we can discuss what's coming down the pipe about PRRT. Raiden, you cannot listen? Can you? Okay, good. So this is the famous or infamous conflict of interest. But I will treat my patients no matter what. Now I'm from Brazil. I'm a soccer fan. Not fan, I'm fanatic. I grew up at the age of 0, and then at 3 years old, my dad was carrying me on his shoulders to watch the soccer game in Maracanã, Rio de Janeiro. I saw Pelé playing a couple of times. So anyway, that's the jersey of my team, believe it or not. My favorite team is a zebra team. And this jersey was signed by all the players from my team, and this is a gift from one of our patients, Wendy Now, who is not here today, but graciously she was able to get that jersey. I don't know how she got it, but she got it, and it's framed in my home, and my dad is jealous. All right, we're going to kind of a recap. I think you all know that. And I saw some discussions about, you go to a doctor, you go to the second doctor. And I think this is not a very new slide. People have updated. But the bottom line is that when we were talking, I didn't want to, interrupt the discussion when the patients were here. But two things are happening. We're going to see in the next slide. That pathway of 5 to 7 years, this is going to get short. All this business about patients going to the doctor and say, oh, I'm having some GI problem. Oh, you got IBS, which I do have myself. And don't worry, you stress out, it's supertentorial, and then you keep it going. Nobody said anything until things happen. I think now things are changing. I can tell you that general practitioners are sending patients for gallium PET CT, which is unbelievable. I'm not sure if it's a good thing or a bad thing, but I see from the good thing, because at least they are worried about it and not let it go and think that the patient don't have anything. I think the patient needs to go after the doctor, because I spend at least 45 to 1 hour with a patient when they come for PRRT to talk about it. And I think it's in the hands of the patient, because if we let those sloppy doctors not pay attention to you guys, especially in these days, healthcare system is not good. They're going to have to see 50 patients in 5 minutes. And that's not, well, this is ridiculous, to tell the truth. So that timeline is going to change, and you can see the pathway: primary care, referring multiple specialists, then someone order the image eventually, And by the time they come in, oh, yeah, you have something. Now, I'm going to show a slide about incidence and prevalence, and I myself have to dissect that. And the way I dissect is incidence and prevalence of the disease. I know my topic is about image and PRT, but I think we need to talk about this. Incidence should not be confused with prevalence, because you're going to see a lot of slides on this. So incidence is the information about the risk of contracting the disease, and prevalence indicates how spread the disease is. So if we keep this in mind, we can move to the next slide, which shows that the incidence or the probability has increased tremendously, over 600% in the last 4 decades. And neuroendocrine tumors are now the second most prevalent, which is incidence, cancer after colon, more than colon, pancreatic, gastric, esophageal, hepatic cancer, or any of these two combined. So why is that? We all ask ourselves. I think patients are crying. Patients are asking. And doctors are having to be more proactive. And I tell that it's patients is so important to ask, because then they're going to go after it. I would not deny that the technology has improved. I would not deny that we have more resources, which actually has improved. But I think that disease has been there too. And we are just being more proactive. And hopefully we're going to continue to be even more proactive. So just, 48 out of 100,000 is prevalence, and the incidence is 6.98 over 100,000. Now let's go to what the topic is. What are the imaging studies that we do for neuroendocrine tumors? There's a variety. Ultrasound, CT, MRI, somatostatin receptors, endoscopy, colonoscopy, endoscopic ultrasound. But I'm going to focus in my area, which is nuclear medicine / radiology. So what are the type of scans that relates to radiology or radiological studies? So we have ultrasound, we have CT, we have MRI, we have scintigraphy. You all probably very much aware of that. I'm going to touch about some scans that people don't address as much, but they're still being used. We do those. I'll show you some interesting cases. And somatostatin receptors. What is their purpose? To diagnose, to guide treatment, to look at the treatment response, of course, besides the patient clinical scenario, as well as the biomarkers, and also to follow up. This is an ultrasound endoscopic. I don't do those, but my colleagues do. It's a semi-invasive study. That's a patient with a gastric neuroendocrine tumor. Endosonography image of a small pancreatic net measuring 6 by 7 millimeters. You can see on the picture right there. It's very easy. CT. CT is very important. We can't deny it. Probably we are doing more than what we need. The other thing is that it has to be done very properly. You need to know what you're looking for. It's just not CT with contrast. Sometimes, especially if you're looking at the liver, you need to catch the phase of the liver that you're doing the scan. So it's not as bread and butter, because if you do as a bread and butter, you're not going to see what you're looking for. In this case, this is a triple phase CT scan, approximately 70% replacement of the liver that you can see here, all these white dots. And on B is the venous phase, that's the arterial phase, and that's the equilibrium phase. So that should be done in that fashion. You catch all the phases of the contrast going through the liver, otherwise you ain't gonna see the lesion. So that has to be done properly. By the way, I don't do those, but I certainly work very closely to my colleagues. MRI. That's just one example. Also, you have on axial images from early arterial phase, you can see peripheral enhancement of the lesion, which is important, means that tumor is avid, and the coronal portovenous phase. So one of the things that can be very tricky, if you see a lesion like that, a lot of times if you don't have enhancement, you don't know if it's a cyst, if it's not a cyst. Of course, that there are some parameters to try to discriminate it, but it's very important to have contrast on that studies. Now let's move to what I do every day. So we got actually 4 types of scans. I-123 MIBG, still use it, and I'll show you why. Then we're going to go after the other ones. So this is a patient with metastatic carcinoid tumor and unknown primary. And you can see the whole body images. And this patient has, on the SPECT superimposed, you see those little yellow dots? Those are lymph nodes. So this is a patient that got MIBG, methiodobenzyl guanidine, for carcinoid. Now, we used to do this 25 years ago as the bread and butter. We didn't have gallium, we didn't have Octreotide, and this was the only thing that we have for carcinoid. This is a patient with pheochromocytoma, which is a rare orphan disease, but we do see those too. And in this particular case, if you pay attention, what's in red is a bone scan here with a lesion in the humerus. And if you look at the MIBG, nuclear medicine is not that clear like a bone scan at CT. Some people try to say unclear medicine, but it's not unclear. Actually, it shows the physiology. So here's the bony lesion. This is in green, a liver lesion. And then you also have a lung lesion, which is in red here too. So bony, lung, and liver. That's a patient with sputoganglioma too. And look at the bone scan, it's not that impressive. There is some metastasis, but bone scan is not supposed to see soft tissue, but you can tell there is a bunch of hot spots, scapula. But then when you do your MIBG study, look at this. You'll see soft tissue, you see the bones. Of course, it's not the high definition quality of a PET or CT. And these are images that we do after the treatment with MIBG because we have a high dose in the body, and then the patient comes back 3 or 4 days later, and we put them on the scanner, and then some lesions that we didn't see was the low dose of I-123, we can see after the treatment with MIBG, which is 500 millicuries. We have just published a paper in the Journal of Nuclear Medicine with the highest number of patients that I'm aware of in the country. This is a patient with sputoganglioma. I saw this 2 weeks ago. I couldn't believe it. I thought they changed the patient's name, but that patient had a sputoganglioma and involving the entire skeleton. Everything that you see in the bone is cancer. Is a sputoganglioma involving the whole bones. The patient got treated. Look at this. You see soft tissue. There is no bony lesions anymore. I couldn't believe it. I checked 3 times. Chemo, actually. No, it was not MIBG. It was chemo. I was fascinated. It was incredible. I mean, my face felt. And, I mean, it's good to read scans like this. You go happy home, or you go home happy. You know, you're tired of seeing things and say, "Oh my God." So anyway, that was one, and I like to bring those cases because this makes us happy, optimistic. You know, it doesn't matter if it's PRT. You know, we just need to take care of it. Neuroblastoma, that affects the kids, unfortunately, babies. We see that. We actually had done several trials on it. This is a patient that 10 months old, previously healthy boy, abdominal mass detected on an ultrasound and was confirmed to be a neuroblastoma. Look at the size of that mass. This is his bone scan. And look at the mass, shows up even on the bone scan. This is just the MIBG study showing the big mass in the abdomen, no posterior view. They can get treated, by the way, too. Some will respond very well. I-131 MIBG, and it's fascinating because the dose in adult is 500. In kids, escalate all the way from 6 to 800 millicuries in a body like this size. It goes higher than in adults. And we're going into a trial right now for these babies. And it's fascinating, they respond. We follow them up and they're disease-free. Some unfortunately don't, but some do. But they have options, that's the thing. Let's move to Octreotide, you're all familiar with, Octrescan. And that's a classic, normal Octreotide. You do image at 4, you image later at 24 hours. And, you know, classic, you see liver, you see, you know, the kidneys, and that's a normal scan. This is a patient with unknown primary. It was an Octrescan. And there are, of course, hepatic lesions, para-aortic lymph node, and a pelvic metastasis. But you can see that the definition is not that great. You can catch it. I mean, if you don't have anything, if you don't have gallium, I will show you, then that's what you can. That's what you do. So this is what I call the resident. This is the classic Octrescan on a patient with a pancreatic mass. Without metastatic disease, you always see I call a big blob in the center of the upper abdomen. This is a pancreatic mass. It's a gastrinoma, period. The skin looks the same. If you don't, you know, just look at the abdomen, you don't need to tell the gender, the age. It's classic. It's actually tumor board case or exam case. Luckily, no metastasis. So what about MIBG versus Octrescan? Do they see the same thing? Of course not. They are targeting different receptors. And therefore, there are actually some people doing both. Here's one example. That's a patient with a paraganglioma where the Octrescan takes up, but the MIBG doesn't. So he's not going to benefit from any treatment. Oh, in this case, there is no room for doing any intravenous therapeutic treatment with I-131 MIBG, but it just shows you the difference in both depending what kind of receptor they have. This is the same patient, believe it or not. Is a patient that has a pancreatic neuroendocrine tumor, and interesting enough, the Octrescan show a bunch of soft tissue lesions, liver, lymph nodes, but look at the MIBG. The bone lesions doesn't show up on the Octrescan. As they say, go figure out. Yeah, but it's real. I mean, and we are trying to actually, depending on the tumor burden in one scan, we are trying to do the other scan as well to see, you know, there is actually a study going on that's actually using MIBG and lutetium for patients with neuroendocrine tumors to our MIBG avid and also somatostatin avid. So we'll see what the results are. It's very embryonic still. Let's move for I call the gold standard, PET-CT. And I'll show you some interesting things. You're already seeing FDG PET, and I'll tell you what's also is happening right now. So I think there is no question in our eyes that a Indy-111 Octreotide or Octrescan versus a gallium dotatate. I mean, all of us here can see that this is a much better, much nicer, high definition study. Look at the adrenal glands, the liver, the kidney. Here you don't have the same resolution definition that a PET-CT can do or a PET gallium dotatate can do. And of course, these are areas that goes. You all probably know too. I would say that by now you guys know as much as any doctor what the skin should look like. But basically the pituitary gland, salivary glands, thyroid, spleen, liver. So because it goes to all those areas, sometimes is a little difficult to say, is this a disease, is this not a disease, depending where it goes. So a screening criteria was developed, and this is what's being used now. Because these SUV measurements, we are not confident on it, because they change. I can take the same patient, give the same dose, put the same scanner, wait for the same time, and scan the patient. I'll bring that patient the next day and do the same dose, the same scanner, totally equal. There'll be a 20% variance. And not only that, the SUV can go up and down. So we can rely on SUV. We don't. And this now is being more and more accepted. So what you need to do is to use the criteria from Octreotide and compare what you worry about it relative to other organs. Usually, if the liver is not involved, we can take the liver, but we can do with the spleen as well. But here it says, relative uptake score, none, much lower than liver, slightly less or equal to liver, greater than spleen. Of course, like I said again, repeating myself, if the liver is all involved, you're going to have difficulty in finding an error that's normal. But usually the spleen is okay. So the spleen usually is the one that we take it because it's rarely involved. Our colleague surgeon can correct me if I'm wrong on that. So the cranial score should be reported because it gives us a big guidance about if it is or not a positive study. This is just an example of a Octreotide scan, and again, a PET gallium. This was published. I mean, there is no way to compare the two because this is like day, this is a little bit of the night, you're in the dark. Look how many lesions you can see it, and you can't see here on the Octreotide scan. This is another example which is a little drastic. It's a negative scan. Look at the gallium. Mets in the bone. So if you get the scan and say, oh, there is no neuroendocrine tumor avid, you're not going to benefit from treatment, and then you do the gallium scan and say, whoa. So if at all possible, I would highly recommend to get a gallium PET CT study. Try to the next place you can go and go get it. Comparison. Diagnostic accuracy is very good for Octreotide scan. Oh, this is superior for detection of small lesions, net spot. That of course. Patient convenience. This is a 2-day study. Patient comes in and come back the next day. Nobody likes to do that, especially if you live in far, or even if you live in close. You got to work. You got your things to do, and we're just doing 1 day. It's just 2-hour protocol. Come in and come out. Radiation dose, look at that. The radiation is much lower. This is fantastic. The thing is that readily available. At the time of that slide, not commercially available. No, you can get it. This is a note slide. Correction to that statement. You can get a gallium PET CT scan almost anywhere now. I mean, at least close by to where you live. Well, let's look a little bit of the guidelines, right? I read a statement the other day that fascinated me. Guidelines are not rules. And I think that's true because guidelines made you guide you, but you make the rules with your own patient individually. So that's the way we should operate it. So if you look at the guidelines, this is what you see. Multiple imaging modalities, right? But look at that. PET-CT guidelines right there with CT and MRI. And then next, that's the beauty of it. You see, you treat it. You see with gallium, you treat with lutetium dotatate. So I don't think there is nothing more fascinating than that, than our surgeon taking all these tumors out before we do this. This is a slide from Dr. Richard Baum, who actually, illustrating different imaging stages, tumor burden from a gallium-68 PET-CT. I'll tell you, this patient will never treat it with PRRT. I'll probably send to the surgeon. No question. We got a case last week that the lady had something like that. There was 4 guys discussing, and I said, "What are you guys brainstorming? She needs to go to surgery. Let's debulk these 2 lesions, then we think about it." I mean, she's not going to benefit from anything that we have but surgery. And after God permits, several years down the road, 38 years old. So, but here you got a little bit of a different situation, and I don't know, there might be room for surgery here too before we go to PRRT. This is, of course, is mesenteric involvement, and is a advanced stage. Now, this case I got last week, and I was so fascinated. The reason being, nobody knew where their primary was, but the patient had neuroendocrine tumor. In the middle of the scan, I stopped with the resident, I said, "Hey, this is the primary. It's in this bone marrow, it's in the ileum. They have done everything, they couldn't find it, and the gallium did." I started screaming loud in the reading room. I said, "We got it." Because as you know, unfortunately, if it's not coming from the GI or the pancreas, we're still struggling with insurance companies to get it approved for sites that are other than the GI and the pancreas. It's going to come. We are pushing forcefully as we can. But this to me was fascinating because now we say, is GI primary? You can't deny payment. You can't deny this patient to be treated. That's just a classic PET-CT demonstrating, some liver metastasis, bony lesions. That patient certainly should go to PRRT. I'm not sure if I will try. You're not going to take this lymph node or take this. I mean, maybe this lesion you could. A little debatable, like our colleague said, you can discuss, but this patient certainly would benefit from PRRT. That's the same patient with the liver lesion, multiple liver lesions, and you see the spleen is hot. That's the way it is, and we have to play with the window. And that's a patient that actually, look, if you don't get the CT on the right phase, you don't know what this is. And people may call this as a lesion, but look at the uptake of gallium. It's not. This lesion has been treated. And that's why there has to be a coordination who is reading the CT and who is reading the PET. We luckily have in our department, we can read both. And we have 2 colleagues that are radiologists and read both experts. But otherwise, we always communicate whoever is reading the CT with contrast and ourselves to make sure that we are on the same page. But there will be discrepancies. CT is not going to see it. We will see it. They won't see it. But the main thing is if we see it, we can treat it because it's taking up. It's physiologic. If CT sees it and is not taking gallium, that may not be an indication or a good outcome. Now, I want to touch an issue that's coming up more and more, and we start seeing this. In the initial phase of the disease, what we see is tremendous uptake of dotatate. And this happened with the, well-differentiated tumors. Low Ki-67, it has to be less than 20. That number here is not quite sure. I will show you the criteria. At some point, it may turn from grade 1 to grade 2 to grade 3 and 4. Oh, that's correct. It's grade 1. Grade 2 up to 20. Greater than 2 up to 20%. So if you change to grade 3 and 4, you're not going to have much gallium uptake, but you start having FDG uptake. And we are now actually scanning patients because a patient may have a lesion that's the Ki-67 is actually less than 20, but on the other hand, another lesion in the liver may have a Ki-67 of 45. That lesion is not going to take up gallium. and therefore you're not going to take up lutetium either. So we are actually now, depending on the grade of the tumor, we are doing both scans. We're doing the gallium and we're doing the FDG. I'll show you an example. This is a patient with primary pulmonary Ki-67325. So this is the FDG, very unimpressive. A little bit uptake. That's a lymph node there, that's another lesion. Look at the gallium. So that patient will benefit. On the other hand, 48-year-old male with carcinoid tumor of the lung, pathological typical carcinoid by disease, behave aggressively. Consideration for lutetium. Well, unfortunately, there is not much gallium uptake on the dotatate, but look at the FDG on the right side. So we're going to have to use chemo, we're going to have to use other resources to treat the patient, but this is a patient that is not going to benefit from lutetium. And that's something that people need to keep in mind, that if the gallium is negative, they need to go to get an FDG scan so that you can stage and try to use something other than PRRT to treat the patient. That's that same patient. Look how interesting it is. That's the gallium, no uptake. But look at the FDG. That tumor is grade 4. It's far advanced. 30 years old woman, diarrhea, right upper quadrant pain, fatigue, nausea, large hepatic heterogeneous mass, stage 4. At the time of final FDG PET dotatate was negative. Now look, that's the FDG uptake. And that will not take gallium. If it takes FDG like that, it's not going to take gallium. So we're at the point that we're starting to select patients, and so we can guide therapy so we can improve outcomes. That's all about. Getting the patient, finding out what needs to be done according to clinical, labs, imaging, and direct to the treatment that will give the most benefit. The take-home message about all these images is that physicians and patients have to realize that direct comparison between studies, PET and other imaging studies, are not equivalent. One is looking at the anatomy, the other is looking at the physiology. And what appears to be disease progression in the first PET study may simply represent more accurate staging. Disease progression confirmed only by comparing like scans over time. We are presently doing is we do a gallium PET CT prior to PRRT, and we do a gallium PET CT 2 to 3 months down the road. Because if you do early, actually, what you're going to find out is that a lot of patients, and I could guess 40 to 50, they look more avid, and you'll say, oh my God, it's getting worse. No, I compare this to a war. You throw an atomic bomb, you start seeing enemies coming out of the ground. There's an inflammation going on, and then it's going to be avid, and then you say, oh my God, we call pseudo-progression. It's not progression of the disease, so you need to wait until those bad guys are dead, and then we just see the good guys, and then we don't see gallium uptake. Next. So, this is the version that we all talk about. We're going to talk about the treatment, the nuts and bolts, how we do at Duke. So again, you see, you treat it, and it's on the top of the line, It's not like below everything from the guidelines. Let's go to the nuts and bolts. So a little bit of information that you may all know. So basically, when you actually infuse the Lutathera, actually it goes into the blood vessels, then it binds to the receptors where the tumor is. It gets inside the tumor cells, these receptors take in and put them inside when they have receptor positive tumor cells, and those particles are causing beta emission, which then is going to kill the tumor. I think that's a nice way to describe, which of course induce damage to those bad guys that we want to kill them. So that's basically what happened when we give lutetium dotatate. Now, I think this is very important. Oh yeah. This is very important because a lot of patients that come to be treated because the medical oncologist says, okay, they need to understand that the hemoglobin cannot be below 8, platelets cannot be below 75, creatinine cannot be above 1.7. Now, there is some flexibility, and sometimes the patient don't know that. They said, oh, my doctor said I'm going to benefit from PRT. Well, it has to go through me before I treat it, because otherwise, instead of making the patient better, I'm going to push the patient through the edge, and I don't want to do that. So we need to be very careful. And we do this between treatments, and every day that they come for the treatment, we do another blood test to make sure that everything is in place. We don't want surprises. So keep in mind that this is a criteria, and we follow this. That's the bed. We're lucky to have a nice facility. That's the administration of lutetium that can be done by gravity, or we don't use the gravity method, which is used probably by 95, 99% of people across the country. Nothing wrong with that. We just think that for us, is easier to do using a pump. That's the gravity method where they have you probably know that, there are two needles inside the vial. We used this in the past to do MIBG treatments. We don't use this anymore. Now we do is this. We got a pump. The syringe is in the pump. This pump is extremely precise. You go with 50 ml an hour. And this is the amino acid on the left side with Zofran and dexamethasone. We actually not giving Zofran much anymore, just dexamethasone from inflammation. I would highly recommend that you all whoever is getting, to get dexamethasone to avoid inflammation in the site, because it can cause side effects, leg pain if it's involving the spinal cord. So we give methasone to everybody. Zofran, we give just sublingual if they get nausea. They don't get nausea anymore. They come with a bag full of food and drinks, some with their laptop, and they just cruise. And they go home and say, what happened? Nothing. I said, we're just killing these guys. So that's the regimen, amino acid, antiemetics, we don't give anymore. And then we keep going with the amino acids to protect the kidney, 30 minutes infusion. It's go on after 30 minutes. It takes about 3.5 to 4 hours. It's just now 1 liter. The process is very simple. It's like change from day to night since we changed the amino acids. 4 treatments, 8 weeks apart. And that's how we do it. That's a patient. That's one of all my patients are favorites. I don't know which one I pick. She's doing great. Now people say, oh, 2 IVs. We do it. We do it because we don't want to mix apples and oranges. So 1 IV is only dedicated to the infusion of the lutetium dotatate, and 1 is just for the amino acid. They don't complain. They feel good. And at least that's the way we at Duke wants to do it. The bathroom, that's not from us, but ours is actually even more complicated than that. And that's the man that comes afterwards to make sure we didn't spill anything. Yeah, we got a whole team. It took a while. It took a few years to get to that point. So this is one of my favorite cases. Would you mind playing to rotate? This is a gentleman that was treated in Germany. 7 years later came. He was actually a friend of Steve Jobs and came to me. Did you click for me? Yeah. So you can see when he came to me 7 years after he got treated in Bad Berker by Dr. Richard Baum, the cancer came back. And then I treated him, look at that, on the right side. He's running marathon. Fascinating, isn't it? You go home happy, you know? He calls me, we talk, we became buddies. That's some of his liver images in the cross-sectional. And that's what Dr. Richard Baum also noticed. Look at this. This is progression, not progression, but improvement throughout the years after treatment. I told him that he's going to probably die from a lightning. But I said, I don't think you're going to die from this. That's another courtesy from Dr. Richard Baum. Look at the response. This is phenomenal. There's still residue in the rectum where the primary is. And I'm not going to start beating a dead horse. You all know the NETA-1 trial. You know, that's why we do this. It's probably one of the most impressive pieces of data that we ever seen. And now the data on quality of life is available, showing that improved tremendously diarrhea, pain, and fatigue. Toxicity. The toxicity, I got to tell you that the toxicity is primarily the nausea the patients would have because of the amino acid. I have not complained, or either they have already nausea. So I'm hard pressed to believe that, you know, the nausea and vomiting is something that's caused by the lutetium-177. And all the other side effects are not that bad compared to what other chemo regimens are. So they are very low. So myelodysplastic syndrome, this is very small. But last week, I got a patient that got bone marrow biopsy, and they said, oh, she now found out that she has MDS. I said, unfortunately, I'm not going to treat her because I'm going to make her worse. And she came late. And I said, you guys have to stop doing this and bring the patient early on, not when the patient is down the line, because I can do miracles. So I'm not going to treat that patient because I'm going to make her worse. So in the MDS that they say, oh, MDS is caused by, no, she already has it, or even suspected. And I have treated with patients with MDS, and it was not good. So I don't want to do it again. So you can see here that MDS in patients that never had it, look at the prevalence. It's so small. So the side effects, in my opinion, compared to what we have available, it's not bad at all. And that's my team that the Beatles decided to be Botafogo. That's where our link, and thank you very much.